At the onset of COVID-19 pandemic, Uganda, like most countries, had little or no capacities to handle, let alone manage, critical care patients. This is because most of the high-standard centers to try out this task mainly concentrated around the capital Kampala and a few scattered in some regional referral hospitals all grapple with the challenges of inadequate human resource and outdated equipment. The COVID-19 pandemic was an awakening call to economic planners and leaders to invest in equipping and improving many of the health facilities that had been earmarked to handle COVID-19 cases. The move has to a reasonable extent cushioned the health sector with partial capacity. The Ministry of Health reveals that all plans to better the sector's capacity are on table.
The ministry has begun reskilling 180 existing health workers. Those are doctors and specialists, both in private and public facilities, in oxygen titration, oxygen management, management of the critically ill, and infection prevention and control to bridge the gap in intensive care management.
While delivering the national budget on 4th June, President Yoweri Museveni directed the Prime Minister and the Ministry of Health to oversee recruitment of more personnel to absorb all qualified doctors in the country into health facilities up to sub-county level.
WHO tells us that we should be having one doctor for every 500 population. So since Uganda now is 42 million people, I think they are using the figure 42 million, it means 84,000 doctors. But we are talking over only something like 5,000 in the government service. So the new minister, the new minister of health, the new prime minister, please, I don't want to hear the issue of unemployed doctors.
However, to date, this directive is yet to be implemented despite the dire need for health services occasioned by the COVID-19 pandemic. Dr. Alfred Driwale, a commissioner at the Ugandan National Expanded Program for Immunization, says recruiting for this current situation may prove difficult since the country lacks qualified personnel for critical care.
The beds were procured, they are installed in all the regional referral hospitals. The elements which are remaining now are ensuring that the specialists to manage patients on those beds are trained to manage the cases who are admitted there. And this is the limitation in some of the regional referral hospitals.
Surprisingly, with the current global scramble for health workers, Uganda has suffered an adverse effect of not paying well her health practitioners. Many have fled the country for greener pastures in countries where human resource is slightly valued.
Currently, the medical officers earn 3 million shillings, and the senior consultants and the consultants earn about 7 million shillings. Just across in Kenya, an intern doctor who has just graduated earns either the equivalent or more than a consultant, a senior consultant here, and it is 200 kilometers, so a 4-hour bus ride. So much so that you were asking about the critical care staff in the COVID treatment units. We have 75 anesthesiologists or intensivists in the country. But just the other day, along Bugoma here at the border, Kenya advertised, and several of them went. Because when you go there, it's just a bus ride away. And some of us, our communities are even across the border. You can as well just walk across the border.
What we need is also to improve our working conditions here. When we met with the president, and he's been saying this many times, pay scientists small, pay scientists small. For doctors, he said a minimum salary of 5 million. That's what he directed the other day. And that should happen. You know, the people are fighting for money. You hear now MPs have got 200 million shillings each to buy cars, which they probably have already. What about getting more money to these health workers so that they can treat people who are going down with COVID. So it's just a matter of who has got more muscle.
Professor Francis Omaswa, the Executive Director, African Center for Global Health and Social Transformation, ACHEST, and former Director General at the Ministry of Health, says the problem is with the lack of health workforce planning. To Professor Omaswa, first addressing challenges of health workforce governance before implementing the presidential directive would be a magic bullet of all times.
Right now, the health workforce planning in Uganda is, I think, not there at all. You find, for example, that new medical schools are being created, even the old ones, and they are starting to train people in courses which are not aligned to the skill needs of the country, to the disease burden of the country, or even to posts which are there in the public service.
Available statistics show that every year, Uganda produces not less than 500 doctors and about 150 specialists. However, disturbing revelations point to the fact that there are over 1,120 young doctors in the streets of Kampala unemployed, adding up to the statistics of many unemployed youth. UBC has learned that following the presidential directive, a few vacancies were advertised for specifically emergency services that are on short-term basis.
So the staff are there, they are ready to work, but they have not been employed. Those who are working are being paid very low salaries. And then even those who are in these risky situations, their allowances are not being paid.
Workers, all of them who die from COVID should be compensated. I've heard some people say that only those who are in the COVID treatment centers should be compensated. Actually, the people who are in greater danger of infection are the ones who are not in the COVID treatment centers. They are the ones who are out there in health centers, in other clinics, who receive all types of patients whom they don't even know whether they have COVID or not. They are the ones at bigger risk.
Infrastructure development for the health sector is another bottleneck that has derailed quality service delivery. Professor Francis Omaswa is saddened by the fact that the expenditure on health per capita, instead of shooting high, it is on a downward slope every financial year.
I was in the Ministry of Health. We were spending like $65 per capita. Today, we are spending like $45 per capita. It has come down. So we need to think, because of COVID, the whole issue of how to build a health system that will prepare for more COVIDs, which are coming.
The National Health Insurance Bill that was hoped to bridge gaps in the health sector financing and facilitate infrastructure development still awaits the President's signature, having been approved by the 10th Parliament.
We need this the National Health Insurance actioned so that there is some additional financing, especially for hospital care, so that even if the primary health care services operate, we are doing well with prevention. Now people have learned how to wash their hands, the toilets are improving, the water resources are improving. But once you reach in the hospital, the resources are inadequate.
However, all is not lost. Plans to rekindle and improve the services of the village health teams are at the tail end. Professor Omaswa, a consultant on health governance, revealed that the President directed on the importance of elevating VHTs from rendering services on a voluntary basis to at least earn a salary not less than 100,000 shillings per month.
If they work well, the awareness of the population, the trust of the population, the access to information by the population will be better. And it should enable us to ease the lockdown, provided that there is a strong community support. There is positive behavior from the people. To me, that's by far the single most important one.
Dorcas Kimono, UBC News.